So the Jean Golding Institute is a central hub for data science and data-intensive research, one of 5 university research institutes, and today we are very grateful that we are sharing this event with the Elizabeth Blackwell Institute for Health. We connect multidisciplinary experts throughout the university and beyond. The Jean Golding Institute collaborates with international and national partners. For example, we collaborate with the Strathmore University in Nairobi, Kenya, who also participated in Data Week, the Institute of Statistical Mathematics in Tokyo, Japan, and national partners such as the UK National Data Science and AI Institute, the Alan Turing Institute. We offer a range of events, training, funding opportunities, and coordinate a data science consultancy service called Ask JGI. You can find more information about all the events and opportunities for collaboration on our website, bristol.ac.uk/Golding. Here is an overview of the week's event, color-coded, seminars in yellow, training in blue, and workshops in green. You can download a copy of these from our website, so do take a look, and please register from other events today and tomorrow. And tomorrow we'll have a networking session at lunchtime via Remo, so I really hope you can join us on that session. Data Week couldn't happen without the amazing support from our collaborators and partners. All the events, including the training sessions, are free of charge, so thank you so much. We also love to hear more from you and to continue these discussions and ideas. So please continue to be part of the Jean Golding Institute chat through our Twitter at JGI Bristol /Bristol Data Week. Also, you can sign up for our newsletter. We send it once a month. We also run a data ethics club every 2 weeks, and you can be part of that. And you can read more about events and news on our blog and website. There is also an invite to hopefully our next face-to-face event, our showcase event on the 17th and 18th of February 2022 at the M-Shed. This will be a family-friendly event open to the public. We will have inspired speakers, exhibitions, workshops, art displays. So I hope you can be part of these. If you like to showcase your research, please, hopefully you can be in touch. And that'd be lovely to be part of these. So now I'm going to stop sharing and I'm going to hand it over to Catherine Dabney, Director of Business Intelligence, Innovation and Transformation at the NHS, and one of the leads of the Elizabeth Blackwell Institute Health Data Science Research Strand, who will be chairing this session. Thank you, Catherine.
Thank you for the introduction, Patty. So I'm delighted to be here today to introducing this session. So as one of the leads of the Elizabeth Blackwell Institute Health Data Science Strand, this is a programme of work which focuses on building the Bristol capacity to carry out the interdisciplinary research that makes the best use of existing routinely collected data to improve health and care services. It brings together researchers and clinicians and other partners with experts in data science, and an interest in how it can address the health challenges that we've got today. At this session, I'm delighted to announce 3 exciting new projects we're supporting, which really demonstrate, I think, our objectives and the aims of the HDR strand. Each of the speakers will talk for a few minutes, with a couple of minutes after each have talked for questions and answers. So I do encourage you to please use the Q&A function on your screens. It should be at the bottom. If you let us know the name of the speaker you're addressing it to, we'll endeavour to make time at the end of each talk to answer those. So I'd like to introduce our first speaker for today. This is Dr. Phil Clatworthy. Dr. Phil Clatworthy is an honorary senior lecturer at the Bristol Medical School of Translational Health Sciences at the University of Bristol. Phil is also a consultant stroke neurologist at the North Bristol Trust, so he's got the feet firmly in both academic and the NHS. And he's also the director for Bristol Health Partners Stroke and Health Integration Team. He's leading a collaboration which are looking into developing a scalable stroke and imaging clinical database to facilitate AI research and innovation and adoption. So thank you, Phil, and over to you.
Thank you very much. Now, really appreciate being given the opportunity to present our work. I'm presenting very much with a co-lead to the project, who is Professor Kate Robson-Brown, who's the director of the Jean Golding Institute, which is very, very fitting. And as you say, this is the project that the Elizabeth Blackwell Institute Health Data Strand has recently funded. As a lot of us know, artificial intelligence is really revolutionising healthcare and has enormous potential to improve health. Increasingly, health and care systems are becoming more data rich, so they're collecting more and more data. And that data is over time becoming more accessible and more useful. And COVID-19 has really accelerated the availability and use of that data at scale. So for instance, there is now a national COVID-19 chest imaging database related to COVID-19. And also the algorithms that are being developed are much more powerful. And as an example, people may have heard in the news that artificial intelligence analysis of imaging on breast cancer mammography or histology for cervical cancer, those algorithms may outperform even expert clinicians in diagnosing those disorders. And we're choosing stroke particularly. I'm a stroke physician, and there are many decisions in stroke that are, I think, ideal for this work, in that they combine imaging and clinical data to come to a treatment decision, which is often treat or not. And this is kind of how clinical decisions are generally, or have been made to date. So you have a scan, you make an interpretation of it yourself, you have a lot of clinical information about a patient, you combine those in your large computer of your brain and come up with a treatment decision. But of course, that's not all you're doing. And there are a lot of things that can influence the decision you make it less consistent. So the situation you're in, if you're in a time pressured situation and you're trying to combine your knowledge of clinical trials in the area that are relevant, whether that patient really fits the criteria for the trials, your own sort of brain processing power, and your previous experience. So if you've had a particularly bad experience in one particular case, you might be more reluctant to treat. And actually your ability to perceive things visually, obviously on the brain scan, makes a significant difference to that. So AI is beginning to help with those things. So we have clinical decision support tools where the imaging is processed in a way that makes it easier to make those decisions. But at the moment, those algorithms only process the imaging and present them to you, and then you have to again combine that with all of the other information that you've got to hand, which is lots usually in your brain to make a decision. So in future, what we will be moving towards undoubtedly is having all of that imaging and clinical data available and combined together in the same sort of artificial intelligence models to be able to come to a much more individualized treatment decision, taking into account all of that information and coming to a consistent decision that's not so dependent on what's happening at the time. So the project itself that I'm describing really is to create this repository of linked clinical and imaging data for research use. And the next couple of slides have been put together by Emma Kuverts, who's a senior data scientist at the Jean Golding Institute, and she's the data science lead for the project and is essentially running the project day to day. And really the project is about creating this repository, so looking at what the challenges are and addressing those. So the data that we're looking at are coming from North Bristol Trust, and largely these three areas. So there's the imaging data itself, the actual imaging files, which are held on a system called PACS. There's clinical data, which is held in a sort of electronic patient record. It's not a full EPR at North Bristol at the moment, but that's being implemented, which is very much facilitating the project. And then there's data about, for instance, imaging reports, what imaging people have undergone, and those systems will then be combined in this data repository, and that's obviously quite a complicated process. So we need to decide what data to extract, how to link those data together using a unique identifier and making the data as complete as possible, and making sure that there's data cleaning and data quality assurance. And of course, this is all patient data. We need to make sure that the personal information isn't available to researchers. Increasingly, as these things become more powerful, the risk of kind of being able to identify somebody from what looks like unidentifiable data it increases, and so that's something else that has to be dealt with. And there are obviously appropriate approvals for data use for both projects, but also then for holding the data in one place. But certainly the personal data won't leave the NHS network. So it won't be visible to researchers. And then the data has to be collected and then curated, really, in order to be useful for predictive modelling, both in clinical care in the long run, but particularly in this case for research. So the different records have to be modelled. So, for instance, what sort of problem does the patient have that's had the scan? One of the things we're going to be looking at an early stage is detecting intracerebral hemorrhage, so that there are a combination of ways of doing that. There'll be things in the imaging reports, so we're intending to try and use natural language processing on imaging reports alongside processing the images themselves, and then there are diagnostic codes as well, and seeing what the best way of doing that is, so that we can sort of segment the population that we're trying to characterize automatically without having to have somebody do that every time. And then make it accessible to people to use. So a trusted research environment, these are things that are being set up now so that the data can be safely stored and used without a risk of re-identifying people. And it needs to be easy for researchers to query the database to make sure that they're getting the data that they want. And then availability for more longitudinal studies, so predicting outcomes. So there are all sorts of things that you might want to do with that, which I haven't got time to go into, but particularly to make this sort of last over time, we need to be able to add data and make sure that the clinical data for a particular patient is added to their existing record and we don't have duplication, for instance. Also, as part of the project, we're going to be developing a community of health data science and clinical researchers that are working together on the data set, and that will be hosted by the Jean Golding Institute. And also during the project, we'll be running academic, clinical, commercial workshops to better understand what people need and how they want to access data, and to facilitate collaborations on future research. So our partners are the University of Bristol, an academic partner, Clinical North Bristol Trust, and also we're partnering with a company called Brainomix, which I'll describe in a minute from a commercial point of view. At the university, there are a number of people that we're working with. So the Elizabeth Blackwell Institute, obviously, the Jean Golding Institute I've described, but also there are many people working within the university in relevant fields. We've done some work already with Professor Majid Mehmedi in computer vision, but one of the limiting factors there has been the availability of data. So it's really exciting that we'll be able to move that forward with this database. And also Jonathan Stern, who's the lead for the Biomedical Research Centre bid, we're hoping to work together to create a sort of imaging strand within that BRC bid, which is going to allow us to scale this work. And Set Squared is a sort of business incubator which supports commercial collaboration. North Bristol, we've got very good support from informatics and also from leadership within the trust. So Rona Galt is a co-applicant who's the Director of Transformation at North Bristol and the lead for innovation and AI. And she's very much supporting the project. And then we have clinical researchers who work in areas that are very relevant to stroke and the clinical decisions that we're trying to support. Brainomix is a company that is already working in the field of stroke, so they already work on these AI algorithms that help to present and analyze brain images to help emergency decision making in stroke, but those currently don't incorporate clinical information into those models. We're working with them on an AI in Health and Care award that they've already secured from NHSX to look at scaling across the UK, and they will certainly provide technical expertise, and the hope is that they will be able to collaborate with them in future to make new AI tools, and potentially deliver them on what is already a cloud platform. And then beyond this, as I say, it's a scalable database, so we will have specific research projects and ideas that will come from this 6-month grant. We're hoping that it will develop into a BRC imaging strand. We want to scale up to include additional data sources and also additional data sets and types. So there's a regional system-wide data set that has a lot of health and social care data in that could be very useful, particularly for kind of segmenting the population by diagnosis. But also there are almost endless applications for this sort of database. So population health management, we currently look at cardiovascular prevention, but we don't look at a brain scan and see whether somebody has evidence of cardiovascular disease on a brain scan, or you can do retinal imaging and you can see evidence of cardiovascular disease in the retina. And similarly, we've got collaborations with operational research. So can you predict by how severe someone's stroke is at the beginning and what their imaging looks like, and clinical information on how long they're going to need to spend in hospital and what their needs are going to be on discharge to make systems run more efficiently. So it was a bit of a whistle stop, and just a couple more acknowledgements again for the funding from the Elizabeth Blackwell Institute, but also I think particularly to Neil Darville, who's the Director of Informatics at North Bristol, who's been very supportive of the work. Thank you.
Thank you very much, Phil. That was really fascinating, and I'm very excited about stuff like this because I can see, as you described, the potential impact it will have in diagnosis and emergency medicine going forwards. We have an interesting question, and I think this is in a nutshell. So we have a question that says, how do you manage to bring such a disparate group of people together? It's a holy grail of academia, but always a challenge to achieve effectively. So any top tips for collaborations going forward?
I think from my point of view, it's been a bit stressful at times, but it's just kind of getting involved in things that look like good opportunities as you go along, and grabbing opportunities to talk to or work with people as you go. And actually, from the health and care point of view, the health integration teams and Bristol Health Partners have been a real kind of exemplar of that, of sitting between organisations rather than within any one organisation. So I tend to kind of sit and be networked as much as I sit in any one organisation, and I try and kind of protect that very much, and I suppose seeing other people's point of views and not being too entrenched in your own views from your own perspective, and trying to make sure that the people you're working with are achieving what they want to achieve. And it's taken years. I mean, it's not. I don't move around from place to place. I've been in Bristol for my sort of neurology training, so I've been in Bristol really for about 13 years so far. And this is really only just sort of coming to fruition, those kind of links into information technology through the hospital. I mean, the clinical academic role is a really useful one. So yeah, part-time in academia, part-time in clinical work, and then you're kind of taken seriously by both camps. I think a bit of a long answer, but I think that's probably all I can say. Just talk to people and take every opportunity to work with somebody, even if it doesn't come off, they tend to remember.
Brilliant. Okay, well, thank you, because I think that's the one of the key questions that I think face everybody across any sectors like this. And then I think there was just a sort of, I suppose, another question is you've got a very broad piece of research there. There's lots of opportunity in other areas and of what could come out with this, particularly population health management, etc. Which bit of this research is sort of gives you? Would you say you're most excited about for the potential impact you think it could have for yourself and your colleagues at the front line of the NHS? I think that would be really interesting.
Yeah, so the things that I can see best are the sort of stroke management early on. So things like, who are we going to perform a neurosurgical procedure on. At the moment, that's all done quite inconsistently, and there are not individualized very well. So there are a number of those, and the neurosurgeons don't like operating on people with stroke if they can get away with it, as you might understand. But those things are often anticipatory, so you're kind of anticipating the need for an operation because the brain's swelling up after a major stroke. And actually, if you can then predict who's going to need to go and have an operation so that you can do it early and actually prevent disability as well as just saving their life, then that's actually a major thing. That's, you know, relatively small numbers of people. But and then, as you say, the population health management really is only just coming on my mind about it, really. But those kind of the ability to prevent cardiovascular disease and not stick just within one condition, but the role that imaging could play in that, because it's just not in there at all at the moment in those sort of data sets. And there's so much information that we've got. You know, that in terms of if you've got files, these are the massive files that you've got, and all the others are, you know, a fraction of the size. There is huge amounts of information in there that we just need to be able to use. So yeah, I think those are probably the two areas, these kind of very invasive treatments that we want to make sure are necessary and going to be beneficial, and then more on the population health side.
Brilliant. Okay, well, thank you very much, Phil. That was really interesting. I'm now going to introduce our next speaker. Again, I'm delighted to introduce Yvette Pine. Yvette is a GP and also an academic clinical fellow and an honorary research fellow at the Centre for Academic Primary Care and Bristol Medical School. And she's been working in collaboration with the School of Computer Science on looking at natural language processing of primary care consultation notes.
Thank you, that's lovely. I shall just share my screen. There we go, thank you. So yeah, fascinating talk from Phil there about computer vision, which is very much, and all the things associated with that. In primary care, where I am, it's a lot more about the text that we use. We write notes, we read notes. So my focus is more around how we can get computers to use that. So hence my interest in natural language processing. So yes, as I say, as you've mentioned, I'm a GP for half my week and I'm an academic for the other half of my week. So a lot of my clinical work informs my academic work and vice versa. And I'm sure several of you have been in the situation. I think pretty much everybody's been a GP in a GP consultation. You go in, you speak to the doctor. Obviously, a lot of it's telephone based these days, but you go in, you speak to a doctor, and they are using a computer. They're using it to look up previous notes they've made or other doctors have made. They're looking up results of yours or reports from x-rays you've had. They might be looking at guidelines to help them guide the treatment that they're going to give you. And I think one of the things that's quite interesting, if you even look at this picture, you've got the doctor is very much looking at the computer. They're not looking at the patient, which you can just sort of see out the corner of the pitch or corner of your eye there. It almost becomes, this computer becomes a third entity in the GP consultation. And I've become more interested in this, in the barriers associated with that, in the way that it potentially is breaking up the patient-doctor communication line, the eye contact, all those sort of things. There's this third entity in the room that the GP is spending perhaps more time than they should do focusing on. And I'm starting to think, is there a way we could pull the GP away from that, enable them to keep taking the notes they need to take and look up the information they need, but with less direct interaction with the computer? I'm wondering if it's possible to build some sort of tool that at the very least could sort of write the GP notes for them, basically, so that they can concentrate on the patient and be paying attention to that. And if you think about what a computer has to do to be able to do that, it's got to be able to process that language, the conversation that's happening between the GP and the patient, and then it's got to be able to translate that into something that is a meaningful set of notes that the GP can look at in the future. So that is what natural language processing does. So for those that haven't come across it before, it's a type of artificial intelligence. It's specifically about translating human language into things that computers can understand, and then allowing computers to create natural language that humans can understand, and this is achieved through machine learning type techniques. You can think about all sorts of examples where it's being used literally all day, every day for you already. So your spam filter is an example of natural language processing. It's working out whether an email is spam or whether it's something that you actually want. There's some really advanced translation features going on at the moment in terms of translating text just from looking at a photo, but also almost real-time communication and translation between multiple languages, which is incredibly powerful. And if you try and think of all the steps involved in that, very, very complex. Every single time you open up Alexa or Google Assistant or Siri, there is a natural language processing exercise going on there where it's understanding what you're saying and translating that into something that it can use and it can understand. And then, of course, there's the silly examples of autocorrect fails where it tries to predict what your next word might be based on what other people have written and doesn't always succeed in doing that. So interestingly, Phil picked up on the idea that data is key. With a lot of machine learning techniques, we need to give the machine data and we need to tell it what that data represents, and then it works out what the rules are that mean that the data, the connection between the data and what it represents. And that involves huge, huge data sets. So I need a data set that's going to start building this tool for me. The one I'm planning on using is one called the 1 in a million data set. So this was created in the Bristol area. It's 300 live real GP consultations that were video or audio recorded. They were then transcribed by human transcription people and then coded based on what happened in the consultation, and that's combined with the GP notes that were actually written during the consultation. And we're just about to get that data come through. I literally had another email this morning saying hopefully that data will be with us in the next week or so. So we're still quite early in this project. So of course, in my naive way, we have this script of the GP consultation, and then some NLP magic happens in the middle, and then miraculously there's a beautiful set of notes that are created off the back of that. I think the chances of us achieving that in a sort of short-term project are quite remote. The step changes you get in machine learning and artificial intelligence often are unusual steps in terms of some things being a lot easier than you'd think and some things being a lot harder. I think this is probably unachievable. I think what's much more achievable is the idea that a tool will be able to work out what body system was involved in the consultation. Perhaps there'll be more than one if there's more than one problem covered off. If we're lucky, we'll be able to perhaps get it so it starts to spot some of the symptoms that might have been discussed during the consultation, and maybe it'll be able to pull through some other information and spot that, for example, a patient with a long-term cough who happens to be a smoker, we need to be considering cancer. And these are the sort of things where we start to develop more useful tools for a GP in pointing out things that they might have missed or extra questions that they might need to ask. So in terms of some more techie detail, I don't know how many more technical people there are in the team. I'm very much a GP. I have a background in IT, but that was increasingly a long time ago. Anyone that works with data knows that there's an awful lot of work up front to clean the data, prepare it. Specifically in relation to natural language processing, you also have to do something called pre-processing, where you're finding out, breaking up a sentence, things that we take for granted, breaking a sentence up into its separate words, working out what different words mean. And for example, a patient might say, "Oh, I don't have any chest pain, doctor." That then you've got to be careful you don't just pull out the word chest pain. You've got to realize that it's part of a bigger story of I don't have any chest pain, and then picking that all up. So that's sort of all part of the pre-processing. And then there's a variety of different techniques and methods you can use. The most simple one would be simply, has the script got the word cough in it or the word respiratory in it? That makes it nice and easy. And that's almost like the baseline level that you can do. And then it's more advanced techniques to see if there's anything clever we can do. Some of the things we'll be using will be related to this concept of few shot learning. And it's because we've got a comparatively small data set. 300 sounds like a lot, but it's actually a tiny, tiny data set. So I think a lot of our work will be around how we can make the most of the small amount of data we've got. We might find we can use other pre-trained models, such as the clinical BERT model, to help it sort of work out that cough relates to respiratory and things like that. As you can see, my technical knowledge isn't spectacular. I'm very pleased to be working in collaboration with Dr. Simpson in the computer science department. and he's a computer science by background, and he's very interested in natural language processing. And then absolutely, please want to say a big thank you to the Elizabeth Blackwell Institute and the Wellcome Trust for the grant that we've been given. It's basically going to enable me to offload some of the hard coding, the actual coding that will be involved in that, to a computer science graduate, and then get a lot of learning from them, so sort of cross-disciplinary learning going on. And I'm pleased to say that, in fact, we've got somebody called Vincent Wong, who we're very much hoping to bring on board straight away in the next sort of couple of weeks once we get the data, to really get things going. So thank you very much.
Thank you, Yvette. That was a really fascinating talk, and you know, my reflection of this is an incredibly exciting area. And I think this is just exemplifies one of the things that we're trying to do in sort of seed funding this sort of research, because although you rightly said it's a very long term, the benefits will be long term. It's I think it exemplifies why it's so important to start this sort of work. Again, so it's a couple of interesting questions coming through about this. So one of them I think about when your research is saying, so for how long after model development would you require a human GP to quality check the AI coded notes? And speaking from a GP point of view, how would you feel about that?
Yeah, I think that's a really interesting point. I think there's, I suppose the simple answer is that I don't think that AI will be replacing GPs at any point in the near future. But I would argue that GPs that use AI may well replace GPs that don't use AI in the future. I think it's about, I don't think it'll be a massive step change. I don't think suddenly we'll be installing a bunch of software and it'll completely change it. It's going to happen slowly over time. My feeling is that what will probably happen is it will get clever and clever in terms of making suggestions and making notes, but it'll still be the GP that ultimately signs off on stuff for a long time. So in terms of how long before, so I think the GP will always be quality checking these. I don't think there'll be, I think we're too far off the ability to just say, okay, well, the GP doesn't even need to see the notes, the AI will write all the notes. I think it's always going to be a sort of a collaboration exercise. Very similar if you think about self-driving cars. Humans will be checking that self-driving cars are driving well for quite a long time until we're able to switch that off. So it's more a question of how long it will be until the GP doesn't need to check it, rather than how soon the GP will need to check it, if you see what I mean.
Yeah, okay. And again, another interesting sort of why did this thought about this. So this question is coming. It says, how do you think patients will feel about the potential automating of their visits?
Yeah. I think, so I've written a paper actually on this. It's a paper called Augmented Consulting, and it's about, I feel really, really strongly about technology should actually be freeing us up to rehumanize patient care. So that idea of the slide very early on of the GP sort of turning away and typing on a computer. I think we've reached this point where computers are really powerful. They're giving us guidelines, they're giving us an awful lot of support. They're allowing us to get to know the patient a little bit better in terms of reading their history in a way that we can't do at the moment, because we have thousands of patients on our list. And none of us can work the 24/7 hours that used to happen. It's just not humanly possible. So there is a loss of continuity, and sometimes the GP notes bring a bit of that continuity back. I would hope that we're not automating the consultation at all, in terms of we're not automating their experience. What we're doing is we're automating all the bits that shouldn't be done by a human. They shouldn't be done by a human that is the caring person, the connection, they should be freeing up all the boring stuff, the typing stuff, the remembering guidelines, all of this stuff that we're not very good at the best of times, and we shouldn't be doing. And we should be freed of that so we can connect with the human in front of us a lot more. So it's actually about automating the boring stuff and rehumanizing the consultation by removing all that boring typing and other bits and pieces.
Great, okay, thank you. And the final quick question is what you've described at your work. So anybody asking, have you got a commercial partner in at this stage?
No, is the answer. My understanding is there isn't anyone that's quite that close with this yet. I've looked in at nuance. So nuance talked about that, but it's still very much sort of dictating and sort of talking to the computer and using human language to talk to the computer, but it's still that third entity in the room. It's still, I'll talk to the patient and then I'll talk to the computer, and it might be through human language. It's still involving this third entity that I don't think should be such a big part of it. I'm having very high level conversations with people at eConsult and Ask My GP, who have very large data sets, about the possibility of using those from a research perspective, because same issue that Phil's got is access to data is the key when it comes to machine learning. But I would be very interested here if anybody has come across company, and obviously all the really big ones, IBM, Watson, Google, they're all doing things in this space, but I haven't found anybody specifically that's doing what I'm trying to do. And there's always the balance of maintaining a sort of the academic independence where possible if the company's not doing exactly what you need it to do.
Absolutely. Okay. All right. Well, thank you very much, Yvette. That's been really interesting. Very much appreciate your talk on that. And I'd like to take this opportunity to introduce our third and final speaker. So Michal Bristol is our Senior Research Associate in Bristol Medical School, Population Health Sciences, and he'll be talking about embedded digital technologies to measure and modulate life space mobility in older adults. And this project's working on in collaboration with colleagues from the Robotics Lab and the School of Computer Sciences as well. So really, again, a good example of proper interdisciplinary research. So Michal.
Oh, thank you very much for that kind introduction. I'm just going to share my screen. Yes, so as mentioned, I'm going to be discussing embedding different types of digital technologies to measure physical activity and movement within clinical research. And this work is going to be carried out with the support of the Elizabeth Blackwell Institute. And as you mentioned, it's cross-disciplinary as we're working with Professor Rossiter at the Bristol Robotics Laboratory. Oh, sorry, just moving to the next slide. There we go. So just to give a very quick overview of the nature of this talk, I'm going to talk a little bit first about physical activity and mobility and how they are related to health and aging, before diving in a little bit more detail to different types of sensors we can use. These include things people might be familiar with for measuring physical activity like accelerometry, but then we'll also talk a little bit about global navigation satellite systems, such as GPS, which can be used to track people's mobility. I think then the best thing to do would be to move on and discuss embedding these technologies in different populations. The funding we have is to embed these in clinical populations, but I feel there is application possible from this within the community. And then I'll quickly move through some of the key takeaway messages from this presentation. So many of us with older relatives may have heard them anecdotally say that they feel the world shrinks as they get older. And this is certainly reflected in some of the literature, that people feel the world and space they inhabit diminishes somewhat as they age. And research suggests that people's physical activity and mobility patterns are strongly related to their health, their well-being, and their independence. And it's important for us as researchers to determine whether particular routine patterns of physical activity and mobility are associated with poorer health or not. These could serve potentially as useful biomarkers, as monitoring changes in physical activity or mobility may allow us to step in earlier to help support better aging. Clinical studies are an ideal opportunity to do this, as we're collecting very detailed data on each individual participant, and we can explore these potential relationships in very controlled ways. What this allows us to do then is to further bring these relationships to the wider population and see in a messier real-world situation whether those relationships are maintained. So many people will be familiar with accelerometry. These are widely used in the fields of exercise science, nutrition, and just general aging even. And they've been a little bit dumbed to death, but they can still provide some very useful information. Essentially, they provide measures of our day-to-day movements that can be coded to match particular activities, different types of physical activities, such as walking or running. And an interesting aspect of this, looking at aging, is they can also detect discrete incidents, such as falls. Many of you will be familiar with these from your own smartwatches and physical activity trackers, which are based on your wrists. However, the research applications of these can be put on the wrist, the hip, or the thigh, and in some ways, these can provide us with far more accurate measures. Using commercial devices can be a little bit tricky because in some regards, they are a black box because each manufacturer has its own proprietary algorithms. While research-focused devices are ideal because they give you access to the raw data, as others have discussed today, many types of data like this are very, very large. So you do need to consider using something along the lines of an artificial intelligence or machine learning approach. In addition, global navigation satellite systems, of which GPS is the best known example, have exploded in popularity in the last 2 decades. Some of the examples of applications of these are given on the right. Everything from tracking your kids, tracking elite athletes, to checking where your cat is in the local neighborhood. These are quite handy devices, but they do again come with the caveat. They generate vast amounts of data, essentially time-stamped coordinates. And you really need a clean pipeline to run that through to really tease out what these data actually mean. Some variables that we can get from GPS-related technologies include the distances we venture from our homes, how we interact with our neighborhood or suburb, so it can pick up the time spent in each discrete location and how you move between them. From this, we can pick out the modes of transport people use, whether they're walking to the local shops or whether they need to take a bus or car. And we can effectively get a feel for the size of someone's world. These sensors are quite flexible, as shown in the examples to the right-hand side. They can be run as a pendant, a watch, or even just clipped to your belt. However, there are some large caveats with using these. If you're predominantly inside, the accuracy is quite poor at times, and they can be give misleading information over very short distances. So if we want to apply these technologies in clinical populations, we need to first figure out if participants actually are comfortable using these technologies. And this is the project that we are going to carry out with the support of the Elizabeth Blackwell Institute. We'll perform some feasibility work across this summer and into the autumn within the Prime Parkinson randomized control trial. We're going to test 2 different types of devices, namely accelerometers and GPS sensors within a patient population. So we'll look at 15 people with Parkinson's and 15 of their caregivers who are themselves older adults. And we'll follow them up over a period of approximately 1 month. And this is going to give us an idea whether we can find any associations between the measures of physical activity and mobility we measure with some of the routine clinical outcomes we are using within the trial. And it's also important for us to know whether these digital approaches are better than traditional standard approaches which use interview or questionnaire-based metrics. So moving on from clinical trials, where we're looking at people under very controlled conditions, we can take the insights we gain from this and potentially think about applying these technologies to the wider population of community-dwelling older adults. Many of these adults living in the community will have their own complex health needs with 1 or more illnesses. It's also important to understand in these real-world conditions how physical activity and mobility are related to their health. And the inverse is also true. We want to see how these conditions, these multimorbidities and comorbidities, may actually dictate people's physical activity and their mobility. And we hope that this would give us important information that we can use then for planning future research, where we might look to make interventions that could help promote healthier aging. So in conclusion, what I want you to take away from this is that these digital technologies offer us an ideal opportunity to passively measure people's activity and movement, and can give us a really good indication of how people interact with the world around them. In clinical trials, we can look at very specific associations between different types of physical activity and mobility, and how these may be related to particular health outcomes. We can then apply this to the wider community in real world conditions. And all of this, we can bring it together then to help us think of new ways to promote physical activity and mobility to improve health and well-being. And one final thing is that digital technologies are incredibly inclusive. So they can be used, as the example showed, with the little soul with the GPS chip in it, in people with cognitive impairment. So you're not relying on people to remember what they've done over the last few weeks. You can actually just track it in real time. So I'd like to say thank you very much to the Elizabeth Blackwell Institute for supporting our work. This is our team at Population Health Sciences under Dr. Emily Henderson, and at the Bristol Robotics Laboratory with Jonathan Rossiter. Thank you very much, and I'd welcome any questions.
Thank you very much, Michal. So our first question is, and I think this is an interesting one, one that you must have thought of in designing this, is what challenges you're expecting to face with older people who may be utterly lost with technology?
Absolutely. I mean, it depends on the device, really. So with the likes of some of the research-focused accelerometers, to an extent, you can fit and forget them for approximately 30 days, depending on your sampling rate. If you're sampling a lot more frequently, it might knock it down to 2 weeks, but you're guaranteed two weeks to a month of really good quality data without the need for a charge. When it comes to the GPS devices, it certainly is more tricky, because if anyone's ever left their Garmin on after a run or anything with the GPS on, you'll find after a few hours it just cuts out. So that presents one level of difficulty, is making sure people remember to charge it, remember to put it on. But I guess finding an approach which limits the amount of interfaces they need to deal with is key. So they're not accessing it through a smartphone app to access the watch. If you just give them a device that can measure it without the need for them to configure anything themselves. But that's probably quite key.
Okay, all right, that's great. So, and we have obviously you're starting to get our colleagues excited about this. So the question is, could it be extended to, I mean, you're focusing on Parkinson's disease at the moment. What about an opportunity to extend, maybe looking at stroke patients as another one area? Have you thought about doing that?
We haven't specifically thought about stroke per se, but we are super keen to maybe expand it to the wider community, as I was saying, people with comorbidities, with multimorbidities, to make it as, I guess, applicable as possible to all older adults with complex and varying health needs. And stroke would definitely fall under that neurology banner.
Okay, fine. And then I suppose the other question that I have on this, and really this is with my specialist area of interest, which is around population health, and particularly how this extends into not just about people, it is clearly about people's well-being, but sometimes we tend to be very health focused when these sort of discussions. But in terms of thinking about this, could it be extended to looking at how the impacts of social care interventions might improve this, and could it be looked at meeting people's social needs or other areas in that other space, or is this more health focused to you?
I think in the first instance we're looking at health applications, but social applications, this would be very applicable to that too. In the nature of the GPS data we get, we can try and get a feel for how people interact with their wider environment. So outside of the home, how long they're spending in their neighborhood, in their suburb, various parts of the city. You can kind of create almost like a range outside of how far someone ventures from their home. And if you saw it diminish over time, perhaps then you could start to intervene in terms of health responses, or indeed social care responses to those metrics. But it's pretty early days at the moment. I think one of the big aspects is building the pipelines that clean the data, and then you can look for associations between those data and various applications. Okay,
all right. Well, that is really interesting. So I'd like to say thank you very much, Michal.
Thank you.
That's been a great talk. So what I would like to add to this is I'd just like to say thank you very much to all our absolutely wonderful speakers. This has been a really fascinating session. And I hope it's illustrated for you as well also what the work of the Elizabeth Blackwell Institute is in starting to see these projects, start these pieces of work up, that we can see that, you know, horizon scanning down the future, we can see that there are real benefits here. I'd just like to say personally that I think the importance of this sort of research into thinking about what the benefits it can bring to the NHS and the wider care sector, you can't underestimate this, and I'm very much looking forward to the outcomes of seeing the outcomes of these pieces of work in the future. So once again, thank you to our participants for giving up their valuable time today, and also thank you to yourselves for your questions. What I'd suggest you do, if you'd like to find out more about the health data science research on the Elizabeth Blackwell Institute, please come and have a look at the website. Please follow us on Twitter. If you would like to get in contact with our speakers and have any further questions for them, again, look on the websites, details are up there. Please reach out and do contact them if you'd like to follow on with